When we think about how machines work, we are basically conditioned to expect, like, a single point of failure, you know?
Right, yeah. Like pulling a fuse.
Exactly. You pull a specific fuse in your car, the radio goes completely dead.
Huh.
Or you sever a specific wire and the lights just go out. It's entirely binary. And honestly, it makes logical sense to us.
We definitely love to map the world out as this really simple chain of cause and effect. I mean, it feels safe to assume that part A exists solely to perform function B.
Right. But today we are taking a deep dive into the human body, specifically the female reproductive system, to see how that whole mechanical fuse box logic just completely falls apart.
It really does.
Welcome to the deep dive, everyone. Today we are tackling a highly specific, anatomically fascinating question for you, and that is, can a prior surgical excision of the Bartholin's glands for recurrent cysts, like, permanently deplete a woman's capacity for high-arousal lubrication?
And for patients facing this procedure, it is a question that understandably causes a tremendous amount of anxiety. I mean, you're looking at a surgery that completely removes a part of the anatomy historically labeled as a lubrication gland.
Yeah, if you view the body like a machine, cutting out a lubrication gland sounds like you are permanently snipping the wire to that exact function. So to find out if that fear actually holds up to biological reality, we have a stack of incredible sources for you today.
We really do. We're pulling from everything.
Yeah, gynecological surgical texts, clinical trials that measure the female sexual function index or the FSFI, and some seriously deep dive physiological breakdowns of the whole female sexual response cycle.
And what we find in these clinical texts is that human anatomy operates on this level of redundancy and complexity that completely defies our mechanical assumptions.
It's totally wild. It is a journey into the hidden, microscopic fluid dynamics of the human body that completely redefines what it actually means to get wet. Okay, let's unpack this, starting with the baseline anatomy. So the Bartholin's glands, or the greater vestibular glands, sit at the base of the labia minora.
Right, exactly.
If you picture the vaginal opening as a clock face, these are two pea-sized organs sitting right down at the bottom corners, so around the 4 o'clock and 8 o'clock positions.
And that anatomical positioning is totally key.
Mm.
They were first described in 1677 by this Danish anatomist, Caspar Bartholin.
Hence the name.
Exactly. And they're incredibly small, usually about half a centimeter in diameter. If you're looking for a biological comparison, they're homologous to the bulbourethral, or Cowper's glands in men.
Oh, interesting. Okay.
Yeah, and under normal, healthy conditions, they just sit there quietly undetected. But during sexual arousal, they secrete this specialized mucoid fluid that travels through a tiny duct to lubricate the distal vagina and the vulvar entrance.
Okay, wait. Here is where I have to push back a bit based on that definition. If they are the designated biological entities placed right at the entrance to provide moisture during arousal, I mean, it stands to reason they are the whole show.
It definitely sounds like that.
Right. Like, if a patient loses them, the well should theoretically just run dry.
Well, what's fascinating here is that the Bartholin's glands are merely a fraction of the lubrication story.
Really? A fraction?
It's a tiny part of it. They act more like a finishing touch at the doorway. To understand where the vast majority of arousal moisture actually originates, we have to examine a phenomenon called vaginal transudate.
Transudate. Okay. When you dig into the vascular data on transudate from our sources, it is just staggering.
It really is.
The sources show that when a woman becomes sexually aroused, blood flow to the cavernosal bodies and the genital organs can increase by 2 to 3 times its normal volume.
Huge increase. The autonomic nervous system initiates this massive localized surge in blood flow, which is known as vasocongestion.
Okay, vasocongestion.
Right. In an unaroused state, the vast network of tiny capillaries lining the vaginal walls are mostly closed off. But with the onset of arousal, the pelvic nerves release these really powerful neurotransmitters.
Like primarily vasoactive intestinal peptide, right?
Yes, VIP, along with nitric oxide.
Yeah.
These biochemicals are potent vasodilators, so they literally force those dormant capillary beds to rapidly open and just engorge with blood.
Wow, so you suddenly have an immense volume of blood packing into these microscopic vessels, which creates a massive spike in pressure. I kind of imagine it acting almost like a microscopic espresso filter.
Oh, that's a great way to put it.
Right, like the hydrostatic pressure inside those engorged capillaries is so intense that it literally forces the clear, watery part of the blood, the plasma ultrafiltrate, to push right through the capillary walls while leaving the red blood cells behind.
That is a perfect way to visualize it. This highly pressurized fluid pushes into the interstitial space and basically begins seeping between and directly through the cells of the vaginal epithelium.
Just right through the tissue.
Exactly. And as it travels through this cellular matrix, the vaginal tissue actively alters the chemical makeup of the fluid. It reabsorbs sodium to ensure the final product pooling on the surface is a perfectly modified, slippery lubricant.
That is amazing. So if you are listening and picturing a gland squirting fluid like a spray bottle, you have to completely scrap that image.
Totally.
It is actually this massive tissue-wide sweating of filtered blood plasma directly through the vaginal walls, combined with like the Skene's glands near the urethra. The entire hallway is doing the heavy lifting, while the Bartholin's glands just add a dab of mucus at the door.
Which naturally reframes our whole perspective on their overall importance to the system.
Definitely. But that brings up a pretty glaring contradiction. I mean, if these two tiny glands are just a microscopic drop in a highly redundant, massive vascular bucket, why do they cause such agonizing medical crises for so many women?
Well, the pathology almost always lies with the plumbing, not the pump itself. The Bartholin's gland produces the mucus, but that fluid has to travel through an efferent duct, which is about 2 to 2.5 centimeters long, to actually reach the surface.
Okay.
Because that duct opens right in the highly trafficked fold between the hymen and the labia, its exit point is exceptionally vulnerable.
Vulnerable because it's practically sitting in the vestibule, right?
Yeah.
So I imagine anything from basic local friction to just thick mucus or maybe localized inflammation from a minor infection could easily block that tiny exit tube.
Exactly. Or even scar tissue from a previous trauma, like childbirth or an episiotomy.
Oh, right.
Yeah, and when that tiny duct gets obstructed, the gland itself doesn't actually receive a signal to stop working.
Wait, it just keeps going.
It just keeps going. It continues producing mucus during every cycle of arousal. So the fluid backs up, the pressure builds, and the duct balloons outward into a Bartholin cyst.
Wow.
And those can grow to the size of a large marble, or in severe cases, even a golf ball.
A golf ball.
God.
But a cyst by itself is often just an uncomfortable, painless lump, right? Like, the clinical descriptions in our sources take a much darker turn when bacteria get involved.
Right, because the vulvar area is naturally rich with flora.
Yeah. So if a common pathogen, like E. coli or a sexually transmitted bacteria, gets trapped inside that sealed, fluid-filled sac, it rapidly converts from a cyst into an abscess.
And that transition to an abscess triggers a really severe immune response. The body deploys white blood cells to fight the trapped bacteria. As those cells die off, they accumulate as pus. So you now have a rapidly expanding volume of infected fluid trapped inside a closed space that is just densely packed with nerve endings.
That sounds horrific.
The resulting inflammatory pressure causes agonizing pain.
Yeah, the sources describe women being completely immobilized by the pain. Sitting down is impossible, walking is a struggle, and sexual intercourse is completely out of the question. The area becomes super swollen, radiating heat, and incredibly tender to even the lightest touch.
It's awful. Yeah. And beyond the immediate physical suffering, this level of localized pain acts as a physiological emergency brake on the entire sexual response cycle we discussed earlier.
Because female arousal relies heavily on the limbic system, the emotional center of the brain and the autonomic nervous system.
Exactly.
If the brain is processing severe chronic pain in the vulvar region, or honestly even just anticipating that pain, it shifts into a sympathetic nervous system overriding. The fight or flight response just takes over.
And the sympathetic nervous system actively vasoconstricts. It literally clamps down on blood flow.
Oh, I see.
Right? So that beautiful tissue-wide vasocongestion driven by VIP and nitric oxide, it is chemically suppressed. The body perceives a threat and shuts down the primary mechanism that produces the vaginal transitate.
So what does this all mean? We have a microscopic tube that is blocked, infected, and causing a systemic pain loop so severe that it shuts down the patient's entire vascular arousal network.
Yeah.
The next logical step is figuring out how doctors intervene. Like, you might assume they just lance it, poke a hole and let the pressure out.
And simple incision and drainage used to be standard practice, but the medical community found the recurrence rates to be unacceptably high.
I mean, it makes sense when you think about it. It's like trying to drain a sink by just poking a hole in a clog.
Right.
The minute you pull the surgical tool out, the inflamed tissue just collapses back on itself, heals together, and completely seals the pipe shut again. You are right back where you started with a blocked pump.
Exactly. To solve the root problem, surgeons have to force the creation of a permanent new drainage tract.
How do they do that?
In an office setting, they often utilize a word catheter, which was actually introduced back in 1968. The physician makes a tiny stab incision drains the infected fluid, and inserts a small, like 5.5 centimeter silicone tube right into the empty cavity.
Yeah, from the literature, it looks like they inflate a tiny saline balloon at the end of that tube to anchor it inside the cyst cavity, tuck the end away for comfort, and literally leave it there for 4 to 6 weeks.
Yes, 4 to 6 weeks.
If you are listening to this and cringing at the idea of a silicone balloon sitting in a highly sensitive area for over a month, you are definitely not alone. But the mechanism is fascinating. They are basically forcing the body to epithelialize the tract.
Right. The tissue is forced to grow a brand new, permanent skin lining around the silicone tube.
Okay, wow.
There's also another variation that uses a Jacobi ring, which threads a looped piece of suture through 2 incisions to accomplish that same forced fistula healing. But if a patient cannot tolerate the catheter or it falls out prematurely, surgeons escalate to marsupialization.
Right, where they make a larger incision, open the cyst, and literally fold the inner lining of the cyst wall outward, suturing it directly to the outer skin. They are permanently stitching the doorway open to create a continuous drainage pouch while preserving the gland itself.
It is a very elegant anatomical solution.
It sounds like it, yet the data reveals a pretty frustrating reality. Even with the balloon catheters and even with the marsupialized pouches, up to 1 in 5 women will still suffer a recurrence.
It's stubbornly high.
The duct blocks again, the abscess returns. When those conservative gland-preserving surgeries fail, the definitive final tier treatment is total excision. Surgeons go in and completely remove the Bartholin's gland.
This raises an important question, and it brings us to the ultimate paradox of this procedure and directly to the core question we set out to answer today.
Right, because if you surgically rip out one of the designated biological moisture factories just to stop the infections, you are surely sacrificing that woman's future sexual function, right?
You'd think so.
Here's where it gets really interesting. One of our sources features a really robust clinical study that put this exact mechanical assumption to the test using the Female Sexual Function Index.
And the FSFI is not just some casual survey. It is a 19-item gold standard clinical diagnostic tool that isolates specific domains of sexual function.
Okay, so it's very thorough.
Very. Researchers specifically looked at the lubrication domain.
Yeah.
They asked patients objective questions about their frequency of moisture, the difficulty in maintaining it, their overall satisfaction, as well as tracking their pain levels.
So they took a group of women plagued by recurrent abscesses and divided them. Half underwent marsupialization, meaning they kept the gland, just stitched it open.
Right.
The other half underwent total gland excision. They completely removed the organ. They ran the FSFI questionnaires before and after the surgeries, and the results completely obliterate the fuse box theory.
The data demonstrated that total removal of the gland did not cause dryness. In fact, the excision group, the women missing the gland, entirely reported statistically higher scores in postoperative lubrication, overall arousal satisfaction, and drastically reduced pain compared to the group that preserved the gland.
I mean, that is just wild. It is the biological equivalent of cutting the wire to a speaker in your car and somehow getting a richer, more powerful sound out of the stereo. You remove a lubrication gland, and the patient's lubrication scores objectively increase.
It's counterintuitive, for sure.
We have to break down the why behind this, starting with the sheer volume of the transode.
Right, so the first factor is simply a matter of scale. Because the overwhelming majority of arousal moisture is driven by the tissue-wide plasma sweating we described earlier, the total volume of mucus contributed by a single Bartholin's gland is just negligible.
It's basically a drop in the bucket.
Exactly. The broader vascular transudate system is robust enough to easily compensate for the loss of that localized mucus.
Okay, so that proves the system is redundant enough to prevent total dryness. But redundancy alone doesn't explain why their scores actually improved. That requires looking at the second factor, which is the complete removal of that neurological emergency brake.
Yes. We discussed how the agonizing pain of a recurrent abscess forces the limbic system to trigger a sympathetic vasoconstricting override.
Right, the fight or flight.
Right. A woman trapped in a cycle of recurrent abscesses lives in a state of chronic pelvic pain and severe anxiety regarding her genital health.
I can't even imagine.
Even when a cyst is temporarily drained, the looming fear of recurrence keeps her nervous system on high alert, and that continuously suppresses the vasocongestion required for transudate.
So by completely excising the rogue gland, the surgeon doesn't just remove a piece of tissue, they permanently eradicate the source of the trauma. Once she heals from the excision, the patient is granted absolute, definitive certainty that the agonizing abscess will never return.
And the psychological and physiological relief there is profound. The limbic system finally stands down. The sympathetic emergency brake is released. By ensuring the pain never returns, the body's natural arousal network is permitted to function at 100% capacity again.
That makes perfect sense.
The return of a massive, uninhibited, pain-free plasma transudate vastly outperforms whatever minor contribution the diseased Bartholin's gland was attempting to make.
So you aren't breaking the machine by removing the gland. You are literally extracting the localized stressor that was short-circuiting the entire systemic vascular network.
Precisely.
And that ties directly into the third crucial factor mentioned in the clinical literature, the undeniable role of estrogen.
The clinical texts emphasize that as long as a woman's vaginal tissues are healthy and well estrogenized, the absence of a Bartholin's gland poses almost no clinical issue for sexual function. Estrogen is really the foundational key to this entire vascular response.
Right, and it goes even deeper than just general tissue health.
Yeah.
Estrogen is the hormone that maintains the structural thickness and elasticity of the vaginal epithelium, and it acts as a primary vasodilator.
Yes.
It is the gatekeeper that allows those capillary beds to respond to the VIP and nitric oxide in the first place.
It primes the cellular environment, allowing the hydrostatic pressure to effectively push the plasma ultrafiltrate through the tissue walls. Without it, the whole system struggles.
Wow. So, to summarize the journey we've taken today, we started with a very logical, mechanical fear that surgically losing the Bartholin's glands equated to a permanent depletion of high-arousal lubrication.
Right.
But we discovered that female arousal is not dictated by a localized mechanical pump. It is a massive, tissue-wide vascular event driven by plasma ultrafiltrate. By removing a diseased rogue gland, surgeons are effectively eliminating a massive neurological pain barrier, which unleashes the body's much larger, blood flow-driven transudate system to thrive once again.
If we connect this to the bigger picture, it is a striking reminder of our evolutionary biology. Human anatomy rarely relies on a single, fragile point of failure for vital reproductive function.
Yeah.
The body builds in resilient backups, vascular redundancies, and tissue-wide responses that can adapt and compensate just brilliantly.
It fundamentally changes how you view the architecture of the human body. And for those of you listening, I want to leave you with a final provocative thought to mull over based on the mechanisms we've uncovered today.
Oh, this is a good one.
Since we now know definitively that arousal lubrication is a massive vascular event driven almost entirely by capillary blood flow and unlocked by hormones, consider the impact of the natural aging process.
Specifically, the systemic shifts that occur during the transition into menopause.
Exactly. The clinical sources detail how the systemic drop in estrogen during menopause leads to a thinning of the vaginal walls, decreased vascularization, and a body-wide state researchers call inflammaging.
Right.
Given that estrogen is the fundamental key required to unlock vasocongestion and plasma transudate, this natural systemic hormonal shift might actually be a far greater threat to a woman's capacity for lubrication than any localized surgical excision of a gland ever could be.
It forces us to look past the visible anatomy and recognize the microscopic biochemical drivers underneath.
It really invites you to wonder, how much of our sexual health, our physical comfort, and our lived experience is dictated not by our local anatomy, the visible gears and wires, but by the invisible whole-body symphony of our hormones and vascular networks.
It's so interconnected.
Because it turns out the body is nothing like a fuse box. It is a highly resilient, deeply interconnected living ecosystem. Thanks for taking this step dive with us. We'll catch you next time.